Hello again, this is Earl Silverman, Editor-in-Chief of the Journal of Rheumatology, welcoming you to my interview of an article of particular interest from the February 2025 edition of the journal. Today, I will be speaking with Ms. Nathalie and Dr. Gilles, who are the first and senior authors, respectively, of our featured article titled Changes at Presentation in Patients with Early Rheumatoid Arthritis, a 24-year study of the early undifferentiated polyarthritis EUPA cohort. You can tell I'm a pediatrician when I say things are 24-year-olds on a 24-year study. And I want to thank you both for taking the time to speak with me and to our listeners on behalf of all the authors of your paper to discuss the findings of this important paper. So with that, we'll start. And can you give us an overview of the clinic itself, the early arthritis clinic in Sherbrooke, and the rationale for the study?
Yeah, for that, we have to go back to the rationale of why we established the early undifferentiated polyarthritis, or EUPA study. It came from the discovery by Dr. Henri Ménard and myself in the late 1980s of antibodies highly specific for RA that we call anti-SA. Anti-SA were shown later to target citrullinated vimentin and thus to belong to the family of anti-citrullinated protein antibodies, or ACPAs, that are currently detected mostly using anti-CCP. The first objective of the EUPA cohort was to validate our clinical impression that RA patients producing anti-SA had a more severe clinical course and outcomes. Back in the 1990s, very little was known about the early stages of rheumatoid arthritis. We thus designed a prospective cohort in which we planned to collect clinical data as extensive as was compatible with real-world clinical practice and the most diversified biosamples we could afford with the limited budget available. So the design was made very simple. The collection of research data was to be integrated in regular clinical practice. Patients were seen by any member of the rheumatology team during regular clinical work, mostly as outpatients. Inclusion criteria were very few. The patients had an immune-mediated arthritis affecting at least 3 joints at the time of inclusion, and a disease duration of less than 1 year, but more than 1 month. And we excluded patients with infectious or crystal-induced or connective tissue disease or vasculitis. And then we treated the patients in the clinic optimally, aiming at 0 swollen joints as soon as possible, using treatments and strategies available at the time. And then we collected follow-up data at pre-scheduled visits at 12, 18, 30, 42, and 60 months after the onset of symptoms. We put the time 0 at the onset of symptoms rather than time of diagnosis that many registries do, to have as much homogeneity as possible for duration of symptoms upon follow-up. And so after a 1-year pilot in 1997, where we validated the study feasibility and improved the design, EUPA was initiated in July 1998 and remained mostly the same for the last 25 years. The study was funded by Fonds de Recherche en Santé du Québec, or FRSQ, the Arthritis Society, and the CIHR. Recruitment is still ongoing, with now over 975 patients included. 90% of them fulfill either the 1987 or the 2010 RA criteria. And since we collected from the start extensive data and specimens prospectively, we were able to address a large number of clinical questions, and this led to the current study.
Thank you. And so then what what was the aim of the study, of this particular study, now that we understand the group?
Yeah, since, well, the recruitment was ongoing for 25 years. It appeared interesting to look at potential changes in the initial presentation of RA patients over that period. Locally, myself and my colleagues, rheumatologists, we had the clinical impression that our patients were getting progressively older and more often seronegative. We thus use our patients fulfilling the 1987 and 2010 criteria for RA to validate our hypothesis, and it's what we've done in this study.
And leading up to the next obvious question, what was the methodology, and in particularly the time periods? Why did you pick those time periods?
Yeah, we already had all the data for these patients at their baseline visit. So in order, we first looked if there was a change or using time as the variable, and there were evidence that there was a change over time. But we then thought about what had been the major changes in the diagnosis of patients that occurred over those 25 years. And obviously, the implementation of the new classification criteria for early RA in 2010 was such an event. There's a lot of evidence suggesting that patients fulfilling the 2010 criteria tend to have a milder disease at presentation than those fulfilling the 1987 criteria. And we thus divided the cohort as before and after the implementation of those criteria, that is, before and after January 2011. We then considered that maybe there, obviously, in the treatment of RA patients, biologics have been the major advance. Biologics likely did not change the baseline characteristics of patients, but their availability in the early 2000s increased the visibility of RA as a treatable disease among first-line referents, and the reputation of rheumatologists as specialists with potent treatments. We thought that this might have modified the patterns of referral of our patients. And we were also interested in studying outcomes of the patient. So we had to consider this aspect, considering for the outcomes, but it also might have done a difference in the timing or the type of patients that were referred to us. So we divided the period before 2011 into before and after 2005, which is the time when, at least in Quebec, the biologics became available to treat early RA patients. Doing so, we obtained 3 periods of recruitment with relatively similar sized groups of patients.
Okay, thank you. And anything you want to add, Nathalie? That's okay, we'll go on. So could you please review the major findings of the similarities and differences in the 3 years?
Basically, demographics such as age, sex, and BMI remain quite similar, as were the tender and swollen joint counts. The disease activity score also remained relatively stable. Looking at immunogenetics, no change in proportion of shared epitope across the 3 periods. Patient-reported outcomes such as depression score, fatigue, sleep problem were the same. We only noted that pain levels were somewhat lower after 2011 than before. So the clinical disease remained grossly the same. However, there were significant differences Active smoking decreased markedly across each period from 22 to 12% following the same trend seen in the Canadian population, but lifetime exposure to tobacco remains similar at about 60%. The education level increased by 1 year at each level, again following the trend in the population. The symptoms duration at the time of inclusion did not decrease over time as expected, but slightly increased from 3 months before 2005 to 4 months after 2011. 25% of patients received DMARDs at baseline in each period, but steroids were used more from 2005 onwards. The rheumatoid factor and RT-CCP antibody level decreased progressively, with significantly fewer patients classified as seropositive with each successive period, mostly after 2005 for rheumatoid factor and after 2011 for RT-CCP. Levels of CRP and sedimentation rate decreased progressively over each period. Erosive joint damage markedly decreased in patients recruited after 2011 only. Cardiovascular comorbidities increased over each period, and previous cancer prevalence increased to 10% after 2011.
Those are very interesting findings, both the similarities and some of the differences. And what do you think of the implications of this for moving forward for patient care?
Yeah, well, for clinicians, I think it's important to recognize that what we call the prototypic RAs, that is the very inflammatory, seropositive, erosive disease, is and likely will become rarer. And the patients will more and more be seronegative and have lower levels of inflammation, at least in the blood. So it is important to be more reliant for diagnosis on clinical evidence of synovitis and less on paraclinical signs such as increased CRP or erosions or antibodies. And I think maybe the second point for the clinician is that the patients that we will recruit over the next years will likely suffer from more and more comorbidities. This is important to recognize because comorbidities may complicate choices of treatment, and comorbidities themselves need adequate treatment. So I think it's two messages, I think, for the clinicians.
I think it's very interesting that the ages, if I remember right, didn't change, but comorbidities increased. That was just what there was.
There was a trend towards increasing progressively, mostly among seronegatives, but it was not significant.
It will be interesting in the future, as we hope smoking continues to decrease, whether the seronegatives do increase. If we believe that smoking is, so which I think people do, in the production of anti-CCP and other antibodies. So time will tell. So I have one more question, and if, in your opinion, every study has some strengths and weaknesses. Would you want to just review for our listeners what you believe are both of those from your study?
A major strength is our population and health organization. Almost all care of RA patients from our area is given by us, so our observations are likely close to the population pattern of RA. Other strengths were the large sample size, the low number of missing data points, the extensive data collected, including demographics, PROs, antibodies, immunogenetics, serial radiograph score for erosion and joint narrowings, and the simplicity and stability of our inclusion criteria over a quarter century. Weaknesses include a single-center study and homogeneous white population, mostly French-Canadian. In addition, not all eligible patients could be recruited for reasons such as refusal, inability to consent, or failure to refer patient by rheumatologists.
It was impressive, the lack of missing data. I think it's just that for the diligence of, it's a great accomplishment, I think, of the clinic. So with that, is there anything you think we missed that you would like to add?
Well, as you said before, at least in most Western countries, the tobacco smoking is decreasing rapidly and will likely be less implicated in the pathophysiology of RA. But RA is not disappearing. It is predictable that other environmental exposures may come to play a more important role in the development of RA, potentially modifying the presenting or contributing to the modification of the presenting characteristics of the patients, and probably also to the response to treatment and their outcomes. I think it's important to keep track of these changes, or instead of using historic controls from the 60s or 70s, when one is to evaluate the impact of new interventions, for example.
Thank you. That's an excellent point. So with that, I want to thank you both for taking time to review the findings of your very interesting and I believe important paper and the implications for patients with RA and for physicians and anybody studying this disease. To the viewers and listeners, I suggest you read the complete article titled Changes at Presentation in Patients with Early Rheumatoid Arthritis, a 24-year study of early undifferentiated polyarthritis, EUPA cohort. There's also an accompanying editorial titled Rheumatoid Arthritis Treatment Has Changed Dramatically over the past 3 decades, but has rheumatoid arthritis itself changed? By Doctors Hitchin and El-Gabalawi from the Faculty of Health Sciences, University of Manitoba, Winnipeg, Canada, who review the implications of this study. Both the article by Carrie and co-authors and the editorial are available at the journal's website at jroom.org and in the print edition of the February 2025 edition of the journal. And I want to thank everybody for listening and hope you'll join us next month when I will again interview the authors of an article of particular interest from the March 2025 edition of the Journal of Rheumatology. And I'd love to hear your comments on x@jroom or by email at manuscripts@jroom.com. Thank you.